Melanoma incidence is increasing globally.
We should put some efforts in younger population. Primary prevention is the turning point.
Do you see AI potentially improving early melanoma diagnosis?
Not in the future, it's already here.
Ladies and gentlemen, welcome to the EADV Podcast. And this podcast is held on behalf of the EADV Melanoma Task Force. My name is Monika Arenbergerova. I work in Prague in the Czech Republic, and I would like to welcome my two guests. The first one is Zoe Apalla, Professor of Dermatology at the Aristotle University in Thessaloniki in Greece. And she is also a member of the EADV Task Force, Dermatology for Cancer Patients. Hello.
Hi, Monika. Thank you.
And my second guest is Aimilios Lallas. He's also a professor at the same university, and he is the member of Melanoma Task Force at EADV. Hello.
Hi, Monika. Thank you.
Aimilios, recently, International Dermoscopy Society, where you are also the president, published the consensus recommendation for the management of lentigo maligna. So what do you think? What is the role of dermoscopy, but also confocal microscopy in the diagnosis, biopsy, and excision of lentigo maligna?
Huge. The role of all these imaging techniques is very important for diagnosis and also for mapping of the lesion, for assessing which are the borders, because lentigo maligna often grows in subclinically peripheral margins. Therefore, an accurate assessment with imaging is crucial. Of course, dermoscopy, needless to say, that it's the absolute tool, to make the initial assessment. But also, if there is access to confocal microscopy, that's really helpful to delineate the tumor very well. In addition to this, these techniques are particularly helpful to assess the result of the treatment, especially when we select to use non-surgical treatments, which, by the way, in the new guidelines of the IDS, it's highlighted that we have strong data today favoring also the use of topical immunotherapy as a treatment option, of course, together with surgery. That remains a valid option, definitely. So imaging is also important to assess the treatment outcome, the relapses, and so on.
So you think that also for the monitoring of therapy efficacy is dermoscopy important, right?
Absolutely.
Zoe, melanoma incidence is increasing globally. What are, according to you, the most important factors driving this trend today?
Well, in my opinion, there are several factors driving this increase and quite diverse. I think that one of the most important ones is the aging of the population, especially in Western countries. We have this increase of the expected age and life expectancy. And this means that given the association of development of melanoma with the age, it is expected that more melanomas will be diagnosed now and in the future, of course. The second important factor is the historical trend of sunbathing. This is really a serious problem because still many young people go for self-tanning. And not self-tanning, this artificial tanning actually. And they do not realize the impact this has on their skin and the increasing risk for skin cancer in the future. So I think that these are two very serious parameters contributing to this increase. Maybe a third one could be the so-called overdiagnosis, meaning that we have now in our era better ways to early diagnose a melanoma and more precisely diagnose a melanoma. So maybe this increase is also a kind of artificial, but anyhow, in my opinion, the first two factors are the most important ones.
Aimilios, are there specific regions where melanoma patterns are developing in unexpected way? How is it the situation here in Greece?
You mean geographical regions?
Yeah, geographical regions.
Yeah. Well, you mean worldwide? Or?
Yeah.
Well, there is the unique example of Australia, for example, which is naturally explained by the fact that it's a geographical area in which the population living there is not a population that evolved there. They were, the skin is fair skin, so completely inappropriate for the geographical area that they live, and this to a large extent explains the huge difference in the incidence of melanoma in Australia as compared to other countries. So that's a, let's say, unique example. Also, in areas that have for some reason less access to medical care, either because of the situation of the country in general, or because, for example, in Greece, areas that are remote, small islands, and not with no easy access to medical care, that also could create a specific trend of later delayed diagnosis and therefore more advanced tumors. That's examples that I could think. But generally speaking about melanoma incidence, also related to the discussion that we had before and Zoe's comment, I think that this trend that you mentioned, the impressive increase, is something that we experienced not in the last years, in the last many decades. So it's like 50 years now that we experience this continuous increase, obviously mainly associated to the habits of sun exposure that changed in the second half of the previous century. I think that today we start observing a stabilization of this increase in several parts of the world. Australia is the first example to mention, which suggests that somehow we improved a little bit, overall we improved a little bit our behavior towards the sun, and I'm optimistic, let's say, for the future.
Once I've heard that Euromelanoma campaign in Greece is specific, that Greek dermatologists are traveling to the small islands of Greece and they are screening the patients over there, which I found really very nice.
Yeah, that's true? Part of the actions.
Yes, indeed.
Zoe, has public health messaging about UV exposure actually influenced melanoma rate? Are we seeing a real positive impact? What do you think?
Well, in fact, I believe that even though we have done huge efforts and we keep on doing efforts towards this direction, still we don't see this positive impact. We have some exceptions. For example, we know that in Australia and also in Germany, as Aimilios already mentioned, we have a kind of stabilization of this increase. But I think that we must insist with the campaigns and the awareness of the population towards improving this increasing incidence. I believe that we should put some efforts in younger population because we know that primary prevention is the turning point, in my opinion. We should start from the young population and we should try to make them realize what skin cancer means, actually. Because when all of us, when we are young, we do never cross our minds, actually, the idea of having a skin cancer. But I think we should put some more efforts in this primary prevention issue.
Mm-hmm. So let's move to dermoscopy. You are both experts on dermoscopy. Aimilios, in your opinion, what is the most effective way for young dermatologists to learn dermoscopy? And how should they balance between theory and hands-on experience?
The most effective way is to combine the theoretical knowledge with practical use. Dermoscopy is something that you have to practice. Of course, this applies almost to everything. Mm-hmm. But let's say that since it's also an optical technique, a visual technique, it's something that you have to practice also, in addition to learning the theory. And also, it's very important to expose yourself to the way that let's say, experienced or expert people think about it, because this will facilitate very much the way that you're gonna start understanding dermoscopy, in addition to the basic stuff that you can learn easily.
May I make a comment on this? I think that my recommendation, my advice actually would be to start with the theory in parallel with the application of their dermatoscope in every lesion they examine. And also not only on tumors, but also in inflammatory dermatosis and also in scalp diseases, because it is really very important to get an idea of how the skin looks like under your dermatoscope. So theory together with everyday practice with your dermatoscope, and when you acquire a good level of knowledge, then you can visit an expert like Aimilios, for example, and follow for a few weeks or months maybe the clinic, and how do they do in their clinic, how do they approach the patient with the dermatoscope. These are, in my opinion, the pillars of how to start with your dermatoscope. In the end, something very important, for me at least, is to try to correlate what you see with your dermatoscope with histology. At least in these patients that you perform a biopsy, it is a very good advice to compare the dermatoscopical image with the anatomical alterations that the pathologist describes. This will make you better on the diagnostic basis, but also better in treatment choice. Mm-hmm.
Thank you for this advice. But Zoe, for clinicians who are new in the field, according to you, what are the most common pitfalls you have noticed?
Okay, yes. There are a few pitfalls that I'm always trying to correct them, during our daily practice. The young dermatologists, the residents, for example, they are so enthusiastic with dermoscopy. Over-enthusiastic, yes. And when they see the patient in front of them, they start with the dermatoscopic examination, which is, in my opinion, it's a wrong way to go. The diagnostic approach should start with the classical way that we have learned in the university, meaning the history, the inspection, the palpation, everything, and you should incorporate in the end the dermatoscopic image in all these pieces of the diagnostic puzzle, and you will end up with the diagnosis, or sometimes you may not have a definite diagnosis, and then you have to decide whether you should proceed with a biopsy and histological examination. This is a very common mistake they do.
Aimilios, we speak a lot about biomarkers, but they are usually from blood samples, which can help to form prognosis of the patient with melanoma. Are there any dermoscopic features which could help us to predict the prognosis of the patient?
Yeah, it appears that there are. That's a brand new thing. So in addition to the more established, not really, but the more mature, let's say, biomarkers, which are tissue-based and also blood-based genetic tests, or the ctDNA or the ctmRNAs, the circulating mRNAs. These are biomarkers that are, let's say, explored a little bit more in a little bit more advanced stage. The new thing, the new kid on the block are the digital biomarkers, which means dermoscopy serving for this, to predict not anymore diagnosis, but the prognosis of a melanoma. It appears that it works both with the use of artificial intelligence, so artificial intelligence using images to predict the prognosis of new images of melanomas, and by human readers. So we know some criteria that are associated with a worse prognosis, such as blue-white veil, which is associated with a worse prognosis, dermatoscopic ulceration also, and the opposite, we have also positive predictors, so predictors of better prognosis, which are regression structures and the intense pigmentation. Of course, these are very preliminary findings with only a few important but few studies for the moment. It's going to improve pretty soon, I'm sure, but it appears that there is some power there, some predictive power.
Mm-hmm. So you mentioned also AI. So in the near future, do you see AI potentially improving early melanoma diagnosis, or are there still major limitations?
From a technological point of view, definitely yes. Not in the future. It's already here. The issues that have to be solved are not related to the technology, which is very powerful, but to the way that it's going to be implemented in the clinical routine, in the clinical practice. so as to take real benefit from the power of this technology and not you waste it in tasks that are not really helpful. For example, the overdiagnosis problem that Zoe mentioned could worsen with the wrong use of this algorithm. So definitely there is potential. The answer we have to the question we have to answer is how we're going to use it and for which specific tasks.
Zoe, how do you balance sensitivity versus specificity when we speak about dermoscopy when deciding whether to perform a biopsy of suspicious lesion?
Well, in my daily practice, I'm not thinking of my performance in terms of sensitivity and specificity, actually. I work by instinct. Of course, I have to follow the regular rules that we have to follow. And when I have to decide about a biopsy or not, this decision is based on these criteria. If I have a definite diagnosis, I do not perform a biopsy. And to be honest, dermoscopy has helped me a lot towards avoiding biopsies, not only in skin cancer, but also in inflammatory dermatosis and hair disorders. And I think that this improvement of sensitivity versus specificity is a secondary endpoint, let's say, for me.
May I jump in here for a moment? So I was thinking when you asked the question, theoretically, sensitivity is more important than specificity because sensitivity means that you don't miss melanomas. But in practice, I believe that experience and expertise is measured by specificity. So the difficult thing is to take the responsibility to say, no, I guarantee, and I take the responsibility to say that this is benign and you don't need to biopsy. That's the most difficult task in my view, and this is what improves gradually with experience and with time. So maybe in the end, specificity is more important than sensitivity from this point of view, because otherwise, I mean, we could just excise everything and then sensitivity would be 100%, but that would not work.
That's also the difference between AI and the dermatologist, right?
Of course, and also dermoscopy contributed a lot towards the improvement of specificity, yes. Mm-hmm.
So we are approaching the last question, and the last question goes to both of you. We start with the lady. If you could change one thing globally about how melanoma is detected or managed, what would it be?
Definitely, I would try to improve the access to the specialists. Rapid access is crucial, in my opinion, towards improvement of early diagnosis of melanoma.
Mm-hmm. And you, Aimilios? To have one point which you would like to highlight at the end.
Yeah, my point is very banal. I mean, although we have all these fascinating developments both from a diagnostic point of view with the AI, from the treatment point of view with the immunotherapy, with these impressive results in advanced stages, but still I strongly believe that the most important thing is what Zoe said. I mean, come on, that's the most important thing. If I could change something, would be that I would try to make all melanomas diagnosed at the earliest possible stage, because then all the other discussions will be unneeded.
Maybe improvement of histopathological diagnosis in order to not to have any more these gray zone, ambiguous lesions, etc. This could be a wishful thinking.
Yeah, that would be nice, but not the most important.
Of course, it's not the most important because this is a rare scenario.
To diagnose as many melanomas as possible at the earliest possible stage, because there is no question that this is the strongest predictor of prognosis.
So I think that we all agree that
very banal answer.
The screening of the skin is still very important.
Absolutely.
Okay, with this, I would like to thank to Professor Zoe Apalla and to Professor Aimilios Lallas from Greece for having this amazing interview. And I would like also to thank to the audience for watching us.